Welcome back to the second part of our audiobook, Reconstructive Facial Plastic Surgery, a problem-solving manual by Hilko Weerda. In this section we will dwell into the intricate processes in reconstructing defects in the forehead and nasal region. Coverage of defects in specific facial regions. For smaller facial defects, an attempt is made to achieve coverage by means of flap advancement or local flaps. Keep in mind that these flaps should be placed in the resting skin tension lines whenever possible. If flaps cannot be obtained from the immediate vicinity of the primary defect, regional flaps are used. These are larger flaps involving the movement of tissue somewhat more distant from the recipient site. The classic, regional flaps, from the neck and chest are no longer in common use. For the most part they have been replaced by myocutaneous island flaps and free flaps. Even the classic, distant flaps, transferred as tubed flaps from the chest or abdomen over a period of weeks to months, are very rarely used today and have been replaced by myocutaneous flaps and free tissue transfers with microvascular anastomosis. Small facial defects can be excised and reconstructed with small flaps using a technique that will place the scars as close to the resting skin tension lines as possible. Forehead region. Median forehead region. The resting skin tension lines run along the forehead and are perpendicular to the frown lines in the glabellar area. Forehead defects up to 3.5 cm in size, especially when near the midline, can be closed by mobilizing the surrounding tissue. Primary closure can be facilitated by making parallel or perpendicular incisions in the galea. Small defects can be managed with various advancement, rotation, and transposition flaps and Z-plasties. Wedge-shaped defects. Wedge-shaped midline defects that are based on the glabellar or frontal hairline can be closed primarily by making an incision above the eyebrow or along the hairline and mobilizing the forehead skin. The H-flap is suitable for defects approximately 4 cm wide. Incisions are made along the eyebrow and hairline, extending through all layers in their lateral portions. The inferior Burroughs triangles are placed near the eyebrow to preserve the frontal branch of the superficial temporal artery. The brow portion of the flap should be anchored to the periosteum to avoid eyebrow distortion. As a rule, scars are no longer visible by 6 months to 1 year after surgery. A visible midline scar can be revised with the broken line technique or dispersed with a primary Z-plasty. Smaller defects can be managed with a Burroughs U advancement on one side. A double rotation flap can be used to close larger midline and paramedian defects in the forehead. Again, the scars are located principally along the eyebrow and hairline. Soft tissue expansion can also be used for the primary closure of large midline defects. Lateral forehead defects. Forehead rotation. A wedge-shaped lateral forehead defect can be closed by making a long incision behind the frontal hairline, widely mobilizing the forehead skin, and rotating the skin into the defect. A dog ear is excised at the pivot point in the central forehead, and the wound is closed. Similarly, wedge-shaped defects in the lateral forehead can be covered by a modification of the Esser cheek rotation flap. Burroughs triangles are excised below the earlobe and on the neck to close the secondary defect. In the area of the zygomatic arch, the flap should be carefully dissected on the subcutaneous plane to avoid damaging the temporal branch of the facial nerve, which is very superficial in that area. Nasal region. Glabellar and nasal root. A simple U-shaped advancement flap can be used to cover smaller defects in the area of the glabellar and upper nasal dorsum. Burroughs triangles are excised just above the eyebrow, resulting in unobtrusive scars. VY advancement. Trapezoidal rotation flaps are useful for reconstructing defects of the upper nasal dorsum and canthal area. The flap geometry corresponds to a VY advancement, and the secondary defect is closed by mobilizing the surrounding skin. Because these flaps receive a good blood supply from the supratrochlear artery on one side, the pedicle can be kept relatively thin, allowing for good mobilization and downward rotation of the flap. The sliding flap of Barron and Emmett has a lateral subcutaneous pedicle, has proven useful for reconstructing defects located more in the upper lateral portion of the nasal bridge. Besides a simple transposition flap, a specially designed VY advancement flap or VY advancement with a Z-plasty can be used. Nasal dorsum. Because the skin of the nasal dorsum is very tight, only relatively small defects extending across the dorsum can be closed by mobilizing the surrounding skin. Many defects in this area can be closed with local tissue transferred from above or from the side. It should be noted, however, that the skin of the cheek and forehead is considerably thicker than the dorsal nasal skin. Bilobed flap. Superiorly or inferiorly based bilobed flaps have proven excellent for the reconstruction of defects in the nasal dorsum and sidewall. Both small and larger defects can be managed in this way. The first lobe of the flap is moved into the primary defect, the second lobe is moved into the defect created by the first lobe, and the other secondary defect is closed with a small cheek flap. The angle between the primary defect and first lobe should approximately equal the angle between the first and second lobes, and all the angles should be 90 degrees or less if possible. Larger angles lead to greater torsion and a bulkier dog ear at the pivot point of the flap. If the transfer creates a relatively large cheek defect, care should be taken that the closure does not distort the lower eyelid. For this reason, the subcutaneous tissue of the lower wound margin is usually attached to the periosteum of the upper wound margin after the cheek has been mobilized. Island flap. The island flap is based on one or both trochlear arteries, is also useful for reconstructing defects in the nasal dorsum. The bridge of skin between the island flap and the primary defect can be partially or completely divided if the flap shows livid discoloration due to excessive pressure on the pedicle. Riga flap. The trapezoidal Riga flap is another option for reconstructing dorsal nasal defects. Nasolabial flap. Cameron, 1975, suggested using two nasolabial flaps to reconstruct full-thickness nasal defects. The first flap is swung into the defect with the epithelial side inward, after first removing the epithelium from the area that will overlie the septum. The second flap is then used for cover. One nasolabial flap is sufficient for reconstructing a two-layer defect. Cheek flap. If a large defect of the nasal dorsum cannot be adequately covered with a midline Riga flap, it may be necessary to perform a unilateral or bilateral cheek advancement with Burroughs triangles in the nasolabial folds. A better scar is obtained by adding a Z-plasty on the nasal dorsum. The median forehead flap is also useful for this type of reconstruction. Nasal tip. While small defects in the nasal tip area can be reconstructed with local flap transfers, larger defects that extend to the alar and columella require the use of median forehead flaps or the relatively difficult frontotemporal flap. Bilobed flap. The nasal tip area can be reconstructed using bilobed flaps that are based inferiorly, laterally or superiorly. The scars should be placed approximately in the resting tension lines. If the flaps are sufficiently large and mobile, a defect in the upper columella can be repaired concurrently with the tip defect. VY advancement flap of Riga. Larger nasal tip defects can be covered with a Riga advancement flap based on the side of the nose. The glabellar portion of the flap has a trapezoidal design. The flap is mobilized along the opposite nasal flank, and a VY advancement is performed. A small Z-plasty may be necessary with larger defects. The U advancement is another option to correct nasal tip defects. Median forehead flap. The median forehead flap is used to reconstruct larger defects of the nasal dorsum, sidewall, and tip. The flap receives its blood supply from the supratrochlear artery on one or both sides. These vessels can be identified with a Doppler probe. The forehead should be high enough to permit the end of the flap to reach the nasal tip, using a pattern as a guide or template. The width of the flap should not exceed 3 to 3.5 centimeters so that the donor defect in the forehead can be closed primarily without special preparations. The flap can be used immediately owing to its excellent blood supply. The medial vertical scar in the forehead can be dispersed with a primary Z-plasty or W-plasty. If the flap is broad resulting in a tense suture line, we prefer secondary revision of scars that are still conspicuous 1 year after the operation. The flap incision can be made through all layers down to the level of the eyebrow. In the glabellar area, the flap is bluntly dissected with a sponge stick or curved clamp to expose and preserve the artery on one or both sides. The skin incision can then be continued down below the brow level. If one artery is lost, the second artery generally can ensure adequate flap perfusion. The residual triangular defect in the interbrow area is covered with meshed tulle or a similar dressing. About 17 to 20 days are needed for the forehead flap to take at the recipient site. At that time its pedicle is divided and inset into the triangular interbrow defect, which is first cleared of granulation tissue. The interbrow wound should not be reapproximated at the time of flap transfer, as this would distort the eyebrows by drawing them toward the midline. The wound edges should be freshened prior to inset of the flap pedicle. As in all operations, meticulous hemostasis is required. The flap takes from 6 months to 1 year to heal completely. If it is too thick or if unsightly scars have formed, the flap may be thinned, defatted, and the scars revised by means of small Z-plasties or W-plasties. For larger defects, we recommend using 50 to 100 ml tissue expanders on one or both sides before raising the median or oblique forehead flap. Modifications are asymmetric, paramedian forehead flaps and oblique forehead flaps. Larger defects of the nasal tip and alar. Frontotemporal flap. If the median or oblique forehead flap cannot adequately cover a defect, or if larger, full-thickness defects are present, excellent results can be achieved with the somewhat difficult frontotemporal flap. Because of its technical complexities, however, this flap is no longer widely used. The flap is mobilized in stages approximately 16 to 20 days apart. In about 8 weeks, the surgeon can swing the flap downward, freshen the wound edges, and inset the flap into the defect. Stage 1. First, a narrow, superciliary bipedical flap is created. The flap incisions above the eyebrow should be spaced at a width of no more than 8 mm, but the lateral ends can be angled superiorly and inferiorly in a trapezoidal design. The superciliary defect below the bipedical flap is closed by mobilizing the forehead skin. The upper edge of the wound is tacked subcutaneously to the periosteum of the frontal bone to prevent eyebrow distortion. The superciliary segment of the flap is then sheathed with a split-thickness skin graft. The bipedical flap serves merely as a transport flap. The reconstructive flap is outlined in the temporal area to conform to the nasal defect. Split-thickness skin, cartilage, or composite grafts can be added to the temporal flap during the initial sitting. Stage 2, about 15 to 20 days later, the bridge between the pre-lined temporal flap and the transport flap is incised. Stage 3, after a total of 3 to 4 weeks, the entire flap can be raised on its median pedicle, and the temporal flap is inset into the nasal defect. Stage 4, about 3 to 4 weeks later, the pedicle can be divided or opened up, inset to reconstruct the columella, or discarded. Further steps may be needed to complete the insetting of the temporal flap in the nose, or scar revisions may be necessary to improve the outcome. This technique can also be used for alar reconstruction using a composite graft from the auricular concha. Nasal flank. We use small transposition or rotation flaps from the cheek to reconstruct defects of the nasal flank. We shall illustrate some special flap designs that can be used when the flaps described above are inadequate for reconstruction. Flap advancement of burrow. Wedge-shaped defects in the nasal sidewall can be closed using a simple burrow's advancement flap. The scars run along the nose at the boundary of the aesthetic unit and in the nasolabial fold. Median cheek rotation. Rotating the cheek medially on a superiorly based flap results in scars at the boundary of the aesthetic units. Imray's cheek rotation flap. Imray developed a laterally based, wedge-shaped cheek rotation flap for reconstructing nasal flank defects that extend into the lower eyelid. Instead of a Burrow's triangle, a banana-shaped incision is made in the nasolabial fold. The subcutaneous tissue of this flap should be fixed to the periosteum of the orbital margin to prevent eversion of the lower eyelid. For the same reason, the flap should not be sutured under tension. Cheek U-flap. This flap is rarely used because it conforms poorly to the resting skin tension lines, especially in its superior portion. It can be used in cases of tumor recurrence involving the nasal flank and medial canthal area, especially if median forehead flaps have already been used. Banana-shaped excisions can be made at the end of the flap instead of Burrow's triangles. One alternative to the U-flap is the S-Imray cheek advancement. Several practical flap techniques that can be used to reconstruct smaller defects throughout the nasal region, such as the double deformental flap, well suited for reconstructing smaller defects, the bilobed flap, the transposition flaps, the advancement flaps and the double transposition flaps. Island flap. An island flap from the cheek is also useful for reconstructing small defects in the nasal flank area. The flap may be based on the facial artery or may be designed with a subcutaneous pedicle that has an inferolateral or supralateral position in relation to the flap. The skin between the flap and the defect is undermined, and the pedicle is pulled through. Care is taken not to place excessive torsion or pressure on the flap pedicle. Because the subcutaneous pedicle often creates fullness at the pull-through site, this is not one of our favorite flaps. The cheek must be mobilized somewhat more widely than with other flaps to avoid distorting the upper lip. Sliding flap. A better choice is the sliding flap. A sliding flap from the nasolabial fold is well suited for reconstructing the area where the lower or middle third of the nose meets the cheek. Like the island flap described previously, the sliding flap is generally slid into the defect on a lateral pedicle. Nasal alar. Smaller alar defects, especially when less than full thickness, can be covered using small rotation and transposition flaps or an island flap. Full thickness reconstructions. A defect in the alar rim can be corrected by mobilizing the alar as a full thickness flap based on the alar groove and performing a Z-plasty to bring down the superior nasal soft tissues. Anteriorly based alar rotation. Our technique differs from de Nonvilliers in that we use a flap based anteriorly on the nasal tip to bring down the alar rim. This allows us to place the Z-plasty more in the area of the nasolabial fold and cheek, where the skin is generally more mobile. The somewhat thicker cheek skin must be adequately thinned, and secondary refinement of the alar rim may be necessary at a later time. Modification of the anteriorly based alar. Rotation flap. The defect formed by downward rotation of the alar can also be closed with a small, superiorly based transposition flap from the adjacent region. Coverage with a transposition flap. A turnover flap is outlined in the skin above the alar rim defect and turned down to reconstruct the nostril lining. A laterally based transposition flap is then raised from the cheek and nasolabial fold to cover the partial thickness defect. Lowering the alar rim is a full thickness bipedical flap and with a composite graft. The alar rim can also be lowered by making a full thickness incision approximately 7 to 8 mm above and parallel to the alar rim. After the alar has been brought down, the secondary defect is repaired with a 3-layer composite graft from the auricle. Turnover flap and composite graft. A bipedical turnover flap is used for intranasal lining, similar to the technique just described. Then a 2-layer composite graft is used to reconstruct the alar rim. The skin of the composite graft is enfolded to create a natural-appearing rim. Converting a peripheral to a central defect and reconstructing the alar rim with a transposition flap. In this technique, a 2-layer or 3-layer composite graft is inserted to repair the central defect. Wedge-shaped defect in the alar rim. Wedge-shaped defects in the alar rim, no larger than 1 cm, can be covered with a full-thickness composite graft from the auricle. These composite grafts have a success rate of 80%, and livid discoloration during the initial days after graft inset should not cause concern. The skin component should be cut slightly larger than the cartilage, and the fine monofilament sutures should not be spaced too close together. The reconstructed alar should be immobilized for 8 to 10 days. Above all, the dressing should not be changed for the first 6 days, as this would jeopardize capillary ingrowth. Harvesting of the composite graft is guided by a pattern matched to the size and shape of the defect. We generally use the aluminium foil wrapper from suture materials to make the pattern. Nasolabial flap. The nasolabial flap has proved useful for reconstructing larger partial thickness and full thickness defects of the alar. The defect should be carefully measured and the flap designed slightly larger and longer. The flap is less satisfactory for bearded patients. The nasolabial flap is a superiorly based flap that is swung into the defect from the nasolabial fold. It can be infolded to reconstruct the alar rim. In men with heavy facial hair, the end of the flap should be thinned. The hair bulbs will be resected. Generally, there is no need to add cartilage for structural support. If the entire alar has been resected, the alar groove must be reconstructed in a second sitting. The donor defect in the nasolabial fold is easily closed by mobilizing the surrounding skin, which gives a barely perceptible scar. The alar rim can also be reconstructed with a nasolabial flap. Sliding flap from the nasolabial fold. To slide a nasolabial flap to an alar defect with an adequate blood supply, the flap should have a subcutaneous pedicle that is placed laterally above the flap or directly below it. The end of the flap is tapered to create a VY type of advancement in the cheek area. In and out flap of Peers. This flap has an anterior superior subcutaneous pedicle similar to the sliding flap. The anterior portion of the flap is used for lining. The lower portion of the nasolabial flap is partially cleared of fat and inset into the alar defect for cover. Median forehead flap. Besides providing nasal tip coverage, a median or oblique forehead flap is useful for reconstructing large defects in the nasal alar. Bilobed flap from the cheek. In elderly patients with a large excess of cheek skin, an anterosuperiorly based bilobed flap can be taken from the cheek to reconstruct a large alar defect. With older defects, a turnover flap above the nostril can be used for lining, and an alar rim is fashioned by hinging over the lateral part of the first bilobed flap. The secondary defect is closed by mobilizing the surrounding skin. The cheek just below the eyelid should not be mobilized, and the lower portion of the cheek that has been mobilized upward should be fixed to the periosteum of the orbital rim. If the secondary defect cannot be closed by primary mobilization of the cheek, it should be closed by means of an S cheek rotation like that used with large nasolabial flaps or by applying other flap techniques. The columella. Larger defects of the columella can be reconstructed with a nasolabial flap in patients with scant facial hair. An incision is made through all three tissue layers in the alar groove, conforming to the width of the flap. The flap is then outlined to match the size of the defect, mobilized, and pulled into the nose through the incision in the alar groove. The necessary flap length should be measured with a paper or cloth strip and an extra 1.5 to 2 cm of length added. The hair roots can be cut for a length of about 8 mm at the end of the flap. It may be necessary to reinforce the columella with auricular cartilage or with cartilage from the posterior nasal septum. In a second stage, approximately 16 to 20 days later, the flap is detached within the nose and pulled out of the incision, which is then closed. The end of the flap is inset into the alar groove at the incision site, and occasionally it must be completely detached. In some cases, the columellar area may require a later touch-up operation for thinning and scar revision. The nasolabial flap can also be swung around the alar for columellar reconstruction. In this case, a piece of silicone film is wrapped around the raw surface of the flap to avoid maceration of the alar rim. Frontotemporal flap. This flap can occasionally be used for reconstructing the columella, especially when a concomitant nasal tip reconstruction is required. Composite graft. Smaller defects of the columella can be reconstructed with a composite graft from the helix. Partial and total nasal reconstruction. Median or oblique forehead flaps can be effectively used for nasal reconstruction, depending on the size and location of the defect. In other cases, turnover flaps can be used in conjunction with nasolabial flaps or bilobed flaps, or complex flaps may be required. Various flap combinations can be used in the reconstruction of large defects. When a large forehead flap has been transferred, the upper two-thirds of the donor defect can be closed by an H advancement of the forehead skin or with bilateral rotation flaps. If the scalp is hair covered, the superior flap incisions should be placed about 2 cm behind the hairline. The flaps should be securely coated with absorbable subcutaneous sutures. Converse scalping flap, forehead scalp flap. The use of the converse scalping flap is illustrated for subtotal or total nasal reconstruction with partial reconstruction of the upper lip and cheek. The neighboring aesthetic units should be reconstructed prior to the nasal reconstruction. Soft tissue expansion in the forehead may precede the reconstruction. Stage 1. If necessary, a median forehead flap is used for nasal lining. This flap is turned inferiorly and sutured to the residual nasal mucosa. Silicone stents or acrylate struts are inserted at this stage for structural support. The incision for the forehead scalp flap starts above the eyebrow to the right or left of the median forehead flap and is continued upward. For a total nasal reconstruction, this flap should be at least 8 cm wide and should span the full height of the forehead. Care is taken to preserve the frontal muscle as the flap is dissected upward. The scalping portion of the incision curves behind the hairline and ends behind the auricle on the opposite side. This large flap is supplied by numerous branches of the superficial temporal artery along with the contralateral supraorbital vessels. Following careful hemostasis, the entire scalp flap is brought downward with the well-perfused, relatively thin forehead flap. The forehead flap is folded to the desired shape and inset into the nasal defect. The galea and pericranium are preserved and are covered with impregnated gauze or film. We allow the forehead defect to fill with granulation tissue. The soft granulations are repeatedly removed until a firm, stable granulating bed has reached the level of the surrounding forehead skin. Then the defect is grafted with full-thickness skin from the retroauricular and postauricular region on one or both sides or with skin from the supraclavicular region. As a guide, we use a paper or foil pattern tailored to the size of the defect. A full-thickness skin graft from the supraclavicular region can be used for nasal lining as an alternative to the median forehead flap. However, the somewhat thicker midline forehead flap provides a better framework for the cartilage strut that will be inserted later for structural support. We prefer to add supporting materials at a later time rather than insert cartilage grafts during the first operation. If the forehead region has been expanded, large portions of the forehead defect can be closed in the initial sitting. Stage 2. About 3 weeks later, the scalp flap can be incised and eventually detached from the reconstructed nose. The granulations on the scalp are removed, the edges of the flap freshened, and the unused portion of the flap is returned. At this time the forehead defect is again freed of soft granulations and grafted with full-thickness skin. Any necessary corrections such as defatting and scar revisions are performed about 6 months later. Further minor corrections can be added in later touch-up operations. Total nasal reconstruction with the sickle flap. As in other reconstructions following total nasal loss, the forehead skin can be augmented by soft tissue expansion for 6 to 8 weeks before the flap is incised. Stage 1, the skin flap is taken from the median forehead, and its distal end is pre-shaped to form the alar and columella. As with the converse scalping flap, the flap should not be made too narrow. It receives its blood supply from branches of the superficial temporal artery. Nasal lining is reconstructed with a thick split-thickness or full-thickness skin graft from the supraclavicular region. The nostril is stented open with an 8 mm silicone tubing. Incisions can be made over the eyebrow and in the scalp in an attempt to reduce the size of the donor defect in the forehead or close it primarily. As with the converse flap, the pericranium is left intact and is covered with impregnated gauze or a similar dressing during healing of the reconstructed nose. Stage 2, about 3 to 4 weeks after inset of the new nose, the pedicle is first partially incised on both sides and then divided, and the sickle flap is returned to the scalp. Residual defects in the forehead are grafted in the same sitting with retroauricular or post-auricular full-thickness skin. Again, the granulation tissue should reach the level of the surrounding skin. If necessary, costal or auricular cartilage can be implanted at this stage for intranasal support. Stage 3, approximately 6 months later, the flap is defatted and secondary scar revisions are carried out. Median forehead flap with soft tissue expansion. In this technique, the median forehead skin is expanded with a 200 ml envelope for 6 to 8 weeks, and then a forehead flap is incised to match the nasal defect. Nasal reconstruction with distant flaps. Today it is unusual for surgeons to use distant flap techniques such as the upper arm flap or jumping a flap to the face via the wrist or upper arm. Free flaps such as the radial forearm flap may give a poor color and texture match for nasal reconstructions and are used only in exceptional cases where donor sites close to the defect are unavailable. Perforations of the septum. Small perforations. Small septal perforations can be managed with small unilateral or bilateral U advancement flaps, which can be elevated in 1 or 2 layers. Small unilateral or bilateral rotation flaps and bipedicled flaps may also be considered. We have also used anteriorly or posteriorly based mucosal flaps from the inferior nasal turbinate, in which case a small piece of turbinate bone may be transferred with the flap. A second operation is needed for dividing the flap and insetting it into the anterior or posterior wound margin in the septum. Large defects. Oral mucosal flap of Mayer. Mayer described a technique in which a medially or laterally based mucosal flap is first dissected from the oral vestibule and lined with mucosa or a composite graft matching the size of the defect. In a second stage, the flap is brought upward to the defect through a tunnel in the vestibule and septal mucosa, where it is sutured into place. If necessary, the entire anterior nose can be opened up for this operation. The pedicle is later divided. Nasolabial flap of Tipton. Tipton suggested using the Nelliton flap for larger defects. The alar is detached for its full thickness, and the Nelliton flap is sutured into the defect. The upper edge of the flap can be deepithelialized prior to inset. The second side can be left to granulate. 3 weeks later the flap is detached and the alar returned to its original position. Bipedicled flap of Schultz-Coulon. First, the mucosa on both sides of the septal defect is undermined from the front through a transfixion incision, and the defect is freshened. The entire mucosa on one side is then mobilized down to the nasal floor and inferior turbinate, divided, and advanced toward the defect. On the opposite side, the mucosa above the defect is mobilized past the sidewall and dorsum and divided. The mucosal flap is then pulled down over the defect like a roller shade, and the defects are closed. This can also be done with mucosa that is mobilized only superiorly or only inferiorly. In the next chapter we will continue to discuss the reconstruction of the lips.